Natali talking about BFA, Dr. Tolga Aksu talking about cardioneuroablation, and Dr. Vijayaraman talking about conduction system pacing for resynchronization therapies.
Thank you, Dr. Saad. Now, it's my pleasure to introduce Professor Tolga Aksu from Istanbul, from Aydın University, who has been a real pioneer in cardioneuroablation. And now we'll hear from him the odyssey of cardioneuroablation and whether it is really for prime time now. Tolga, please.
Dear Chairman, dear colleagues, it's my distinct pleasure to present the current status of cardioneuroablation in patient with vasovagal syncope. Actually, enhanced parasympathetic tone or autonomic imbalance between sympathetic and parasympathetic system may cause some different clinical conditions, and we know a strong relationship between autonomic imbalance and reflex syncope and carotid sinus syndrome. But in some patients with sinus bradycardia or sinus asystole, paroxysmal or even persistent AV block, in some patients with atrial fibrillation, there might be some relationship between parasympathetic overactivity and the diseases. So also there are some argument about pathophysiology of vasovagal syncope, we basically know that after occurrence of any trigger activity, we see an increase on sympathetic tone. It causes a forceful ventricular contraction and then stimulates C fibers. Stimulation of C fibers may cause three different responses. In the first arm, we see severe bradycardia or asystole due to parasympathetic overactivity, and which is called as cardioinhibitory type. In the other arm, we see a hypotension due to sympathetic withdrawal, and which is called as vasodepressor type. But in almost 70% of patients, both parasympathetic overactivity and sympathetic withdrawal contribute to occurrence of global cerebral hypoperfusion. So basically, if we can eliminate parasympathetic arm, we can eliminate cardioinhibitory vasovagal syncope. This is just a theoretical explanation, but in some patients with mixed type syncope, this is the great majority of group. If there is still vasovagal syncope episodes, despite increase on blood pressure level, we can still try cardioneuroablation according to this theoretical background. But the issue is, can we really detect the localization of this parasympathetic system during our 3D mapping or electrophysiological study? If you look at the real anatomical spaceman, we know that intrinsic cardiac autonomic nerve system mainly contains parasympathetic motor neuron. So if we can detect the localization of this intrinsic cardiac autonomic nerve system, but please don't forget that in human, there are at least 1,500 autonomic ganglia around left and right atrium. But fortunately, in some well-defined area, we are seeing clustering of this autonomic ganglia, and this area called as ganglionated plexus, like a right superior GP, right inferior GP, posterior medial left GP. I will not explain the details. So anatomically, we know the possible localization of this GP area, and if we can achieve this area, we can eliminate parasympathetic system. If you look at the latest ESC guideline about the treatment of reflex syncope, as you know that if there is low blood pressure phenotype, we can try midodrine or flutiocortisone. I usually prescribe midodrine as a first option because after the POTS4 study, we are seeing too many positive data about the midodrine treatment. But if the patient has recurrent and severe vasovagal syncope due to dominant cardioinhibitory response, we have only one option, and this is cardiac pacing. But according to guideline, you should select cardiac pacing in older patient. Why? Because we try to combine all published data about pacemaker, randomized controlled trials for pacemaker, and CNA observational studies for CNA and one randomized controlled trial. But if you look at here, in only 2 studies, the patients younger than 40 years old were included in the study. And at the end of the study, pacing has no effect to prevent reflex syncope episodes in this younger population. And then only patients older than 40 years old were included for cardiac pacemaker studies. But if you look at the mean age was older than 60 years old. So we have no data about the efficacy of cardiac pacing in a younger population. We have no data. But if you look at the CNA paper, the mean age was lower than 40 years old. And we have one randomized control trial, not a sham control, but we have one randomized control trial demonstrating the positive effect of cardiac pacing in this patient population. And in this EHRA document table, we tried to summarize all published data about CNA in patient with vasovagal syncope, and we checked the tilt testing result, because in all CNA studies, authors use tilt table testing to select their patient. In great majority of publication, pure cardioinhibitory type or mixed tip vasovagal syncope patients were included in the study, but just two study, Chinese group tried to demonstrate the efficacy of CNA in patient with vasodilative reflex syncope as well. But according to theoretical background and our anatomical knowledge, I think CNA should have no effect on pure vasodepressive reflex syncope cases, because I cannot explain the positive effect, the reason of positive effect. But there are two studies, small studies, demonstrating the efficacy of CNA in vasodepressive cases as well. In one study, we compared CNA and conservative therapy. This was not a randomized control trial, but we compared these two treatment methods. And at the end of study, CNA demonstrated 77% relative and 36% absolute risk reduction of 4-year syncopal recurrence, rather than conservative therapy. And then we compared CNA and cardiac pacing. And then, as you see in here, at the end of 1 year, CNA and cardiac pacing demonstrated a similar success rate, but in almost 60% of patients, closed-loop stimulation systems were used in cardiac pacing arm. So if we compare CNA and leadless pacemaker, for example, or if you compare CNA and rate drop response pacemaker, I believe that CNA will be more effective, because I don't believe any role of rate drop response or leadless pacemaker in patient with vasovagal syncope due to mechanism. And then we published the first meta-analysis, and we compared the efficacy of CNA with different approach and different mapping methods. And at the end of study, we found that GP mapping method has no role in a success rate. This was very surprising finding, because too many groups use very, very different techniques. But we certainly found that if you just perform right atrial ablation, you will see more syncope recurrences. We believe that the reason will be reinnervation after 2 or 3 years, because if you just ablate right atrium side, superior vena cava area, you will mainly ablate postganglionated fibers rather than a real epicardial ganglia side. So you will see more syncope recurrence during follow-up. And then Poland group published the first and only randomized control trial. This was very, very small study. And again, this was not a sham control study, but demonstrated, you are seeing the inclusion criteria in that study. They mainly included the patient with pure cardioinhibitory reflex syncope patient, and primary endpoint was time to first syncope recurrence. And they demonstrated very high success rate in the CNA arm. The primary endpoint occurred in only 2 patients in CNA arm versus 13 control patients group. And you are seeing the increase on quality of life in patient with a CNA arm. And then a couple of months ago, we published the scientific statement of EHRA, HRS, Latin American Heart Rhythm Society, and Asia Pacific Heart Rhythm Society. And again, we checked the data in all published CNA work. And then we suggested such a flow chart for patient selection. We strongly suggest to use tilt table testing or carotid sinus massage to demonstrate the dominant contribution of cardio inhibitory component and to demonstrate real reflex bradycardia episodes. But of course, to exclude hypotension, we can use 24-hour ambulatory blood pressure monitoring or standing test. And if you see more than 3-second asystolic reflex syncope during till testing, data are in favor of CNA efficacy. No doubt about that. But if there is associated hypotensive susceptibility, in the first step, we should try midodrine or fludrocortisone. If there is still recurrent syncope episode despite this medication, we can try CNA with moderate success rate. But if there is just vasodepressurative reflex syncope, you shouldn't try CNA according to our scientific statement. This is, we write this figure with Mina Chung. This is just my personal approach, not the approach of scientific statement. There are some difference, but I strongly believe that CNA shouldn't be tried in any dominant tip vasodepressurative reflex syncope patient. We should try midodrine as a first option, and we can also try fludrocortisone. If the patient has dominant cardioinhibitory reflex syncope, and if the patient is younger than 6 years old, we have too many positive data, and CNA should be the first option in patient with vasovagal syncope. But if the patient is older than 6 years old, we have very, very limited data with CNA because it's not easy to differentiate structural disease of sinus node or AV block in this older population. So pacing can be tried as a first option. But in mixed tip patient, we should try medication first, but there is still recurrent and severe syncope episodes. And if the patient is younger than 6 years old, CNA should be the first option. But in older patient, again, pacing should be selected. Thanks for your attention.
Thank you, Tolga, for this excellent presentation. And now I will turn to our